Thank you for kind introduction. Thank you for organizing committee for giving me this opportunity to speak about this topic. Actually, long-acting injectables is not yet introduced, formally introduced into South Korea. So I will share some Asian participant data from clinical trials and data for compensated use in Korean patient. Long-acting injectables which are currently used include cabotegravir, rilpivirine, and lenacapavir. In Korea, cabotegravir, rilpivirine was used for clinical trial use purpose, and I have experience for lenacapavir for compensate use program. I pushed. Okay, yeah. As Dr. Tanuma shows us a landmark study for cabotegravir, rilpivirine intramuscular injection are ATLAS, FLAIR, ATLAS 2M, and SOLAR studies. These studies shows cabotegravir, rilpivirine demonstrated non-inferiority efficacy compared to active oral regimen control groups. These study enrolled suppressed patient for switch trials. This shows the study design for FLAIR study. They enrolled naive patient, and after induction phase with dolutegravir, abacavir 3TC, they randomized to DTG, abacavir 3TC, and cabotegravir, rilpivirine intramuscular injection. And 96-week analysis after they made used enrolled the cabotegravir, rilpivirine injection groups, and they follow to until 196 weeks until now. The study shows the biologic success rate was of cabotegravir group was 93.6%. It was non-inferior to oral control groups. And ATLAS 2M study compared cabotegravir, rilpivirine Q4 weeks versus to Q8 weeks, and the study showed Q8 weeks IM injection was non-inferior efficacy compared to Q4 weeks regimen. As you know, the cabotegravir, rilpivirine injection can cause injection site reaction, but study participant shows the number of participants reporting injection site reaction at each visit decreased over time, the first 48 weeks, and remained consistent thereafter. Among the participants for ATLAS and FLAIR trial, there were 7 cases with confirmed biologic failure. This table shows the details of 6 cases of confirmed biologic failure. Among the FLAIR study participants, the 3 cases with confirmed biologic failure had received injections within the permitted window period, and there were emergent resistant mutations developed in the confirmed biologic failure. And the 3 cases with confirmed biologic failure in FLAIR trial had A1 grade, and their BMI was, median BMI was 24 at baseline. With this trial data, European guideline, US guideline, and ISA guideline recommend cabotegravir, rilpivirine IM injection for suppressed patient, and especially US guideline recommend switch to long-acting injectable regimen to relieve pill fatigue or to decrease potential stigma or disclosure concerns associated with taking daily oral medications. Recently, a study of post-hoc analysis was published to summarize outcome for Asian participants across the FLAIR and ATLAS-2M studies through 96 weeks. For FLAIR and ATLAS-2M study, over 41 Asian participants were enrolled for receiving cabotegravir rilpivirine injections. The median age of the participant was 39 years, and 10% were female, and no participant was reactive for hepatitis B virus. At week 96, the 83% of participants maintained viral suppression, but there were several patients with no viral data, but there was no cases with biologic non-suppression at week 96. This table shows the data for adverse reaction. All drug-related adverse events were grade 1 or 2. And across both long-acting injectable arms, drug-related adverse event other than injection site reaction occurred in more than 5% of participants were pyrexia, chills, fatigue, malaise, and myalgia. Only 2 cases withdrew due to drug-related non-injection site reaction adverse event that were abnormal dream, chills, disturbance in attention, fatigue, pyrexia, and sleep disorder for one case. And another one experienced abnormal dream and insomnia, so they withdrew injection. This slide shows the injection site reaction summary through 96 weeks among Asian participants. The median duration for injection site reaction was 2 days, and most events resolved within 7 days. There were 4 cases who withdrew due to injection site reactions among Asian participants. This slide shows the number of participants reporting injection site reactions week by week. The number of participants reporting injection site reaction decreased over the 96 weeks. For ATLAS and ATLAS-2M study, Korean sites enrolled 27 participants for the trials. And among those participants, 20 subjects are ongoing receiving injectables. But there were no cases who experienced biologic failure among these participants, and there were no cases who withdraw injections because of adverse event of injection, long-acting injectables. This slide shows biologic response at week 142 in South Korea ATLAS-2M trial sites. There were no cases with biologic non-suppression, and at week 142, 85% of participants maintained viral suppression with cabotegravir rilpivirine long-acting injectable. Next, I will talk about lenacapavir. Recently, these antiretrovirals, fostemsavir, ibalizumab, and lenacapavir were approved for treatment of resistant viruses. Lenacapavir binds directly between capsid protein subunit, and it can target multiple cycles of virus replications. This shows the study design of Capella study. This study enrolled heavily treatment-experienced patients with multiple drug-resistant mutations. They had non-suppressed viral load, and they had resistant mutations to more than 2 antiretrovirals from more than 3 of 4 main antiretroviral classes. And they had only less than 2 fully active antiretroviral options remaining. There were a randomized cohort and non-randomized cohort, and primary endpoint was more than 0.5 log reduction in viral load from baseline at day 15. And second endpoint was viral load suppression at week 26 and week 52. This figure shows viral load efficacy at week 26. Overall, 81% of participants could receive viral suppression less than 50 copies at week 26. I have experienced one case of lenacapavir for compensate use. He was 43 years male. He was diagnosed as HIV infection at 2005. Before coming to my clinic, he had experienced multiple treatment failure with various regimens. And he came to my clinic at November 2017 for management of virus failure. At the time of initial visit to my clinic, he had multiple drug-resistant mutations like this. And so I tried to use multiple regimens with dolutegravir BID or boosted darunavir or etravirine, or I enrolled that patient to doravirine islatravir trial, and I tried to use fostemsavir as well, but all of these regimens also failed to suppress his viral load. So in 2022, I started lenacapavir injection for this patient. I choose this regimen, lenacapavir, fostemsavir, dolutegravir, and Truvada. After starting lenacapavir injection, his viral load was started to suppressed. At 2023 March, after 6 months later, after lenacapavir injection, he could achieve viral load suppression. So in summary, cabotegravir or rilpivirine is indicated for use in virologically suppressed adult and are no known or suspected resistant to either cabotegravir or rilpivirine. All injection site reactions were grade 1 or 2. Most were injection site pain and short-lived. People living with HIV interested in non-oral options for ART because of private stigma or non-convenience reasons will usually have a greater satisfaction with cabotegravir or rilpivirine injection than continued oral ART. Lenacapavir combined with optimized background regimen demonstrated high rate of virologic suppression in multi-drug resistant HIV infection and heavily treatment experienced patient. Thank you.
Thank you, Dr. Choi.